Dr. Jeff Boris. Welcome to the Dysautonomia webinar, Dysautonomia International webinar. We are going to be talking about the research that we just published in July of this past year. It's the first of 3 papers on long-term outcomes in patients who have postural orthostatic tachycardia syndrome. I'm glad you could join us tonight. Our host is Lauren Stiles, and so she's on with us as well. But I'm going to go ahead and start, and we'll go ahead and present. This is our long-term POTS outcome survey. And a few disclosures. I am a member of the Medical Advisory Board of Dysautonomia International, but I did not receive any money for this research from them. However, Dysautonomia International has paid or will pay for the 3 articles comprising this research to be published as open access. So our first paper, which we're going to be discussing tonight, was published in the Journal of the American Heart Association in July. And it is freely available for you to be able to read and access, so have at it. And then, although the study was performed with patients whom I saw when I was at the Children's Hospital of Philadelphia, I am now in private practice. So, what's been done before so far? There have been 6 studies previously that have looked at outcomes in POTS patients in some way. 3 are from the Mayo Clinic. 1 each is from Portugal, Korea, and China. And all of them have described highly favorable prognoses. The patients were described as symptom-free. The outcome was benign. They have significant improvement. Some patients no longer met the heart rate criteria for POTS, and they had improved functionality. But when you look deeper into these studies, what do we really find? Anywhere from half to 3/4 of these patients still needed medications. Anywhere from half to all of them needed non-pharmacologic therapies, fluid, salt, compression stockings. Over half to nearly 3/4 still had exercise-associated orthostatic intolerance, right? So exercise-associated lightheadedness, tachycardia, that kind of thing. A little over 1/3 were functioning at a normal level at work. One study looked at just a limited number of symptoms, and nearly all were still symptomatic from the COMPASS 31. The COMPASS 31, as you likely know, is a rating assessment of various symptomatology in the setting of autonomic disorders. So really what this showed was that there were some problems with a lot of these studies, okay? So we wanted to take a look at things and really be honest and get a good sense of what was going on with our POTS patients. So we designed the long-term POTS outcome survey. It's a questionnaire based in REDCap, for those that are familiar with it. And a huge thank you goes to Lauren Stiles and Satish Raj, who allowed us to use questions from the Big POTS survey. A lot of you might be familiar with the Big POTS survey, which I believe is still going on, and has collected a lot of data. So we used a lot of those questions. We also used a few questions from Dr. Phil Fisher at the Mayo Clinic. And then we added our own questions, and we looked at diagnoses or diagnosis and comorbidities, treatment, clinical outcomes, quality of life, educational, employment, and social impacts, as well as gynecologic associations. So we're going to talk about the first half of this, the diagnosis and comorbidities issues, treatment and clinical outcomes, as well as quality of life. So who was included in this? Well, these were patients who came from the Children's Hospital of Philadelphia POTS database. We had 941 patients. These were followed at one institution longitudinally, and they were diagnosed by me and or followed by me and my team. They were age 18 years or less at the age of diagnosis or the time of diagnosis. For those patients who were under age 18, their parents filled out the survey for them. So how'd it go? We had 932 eligible patients from the database. 862 had valid email addresses. 271 patients started it, but 44 of them didn't even complete anything, and 227 patients completed the survey. So let's get into it. The demographics of this group of patients showed that the average age of these patients was almost 22 years. There was a statistically significant difference between the females and the males. The males were slightly younger. The duration of symptom onset to the present, the average duration was 9.5 years, so very long time. Not surprisingly, females outnumbered males by nearly 6-1. And there was a huge predominance of white patients. As has been discussed previously, though, because of access problems and probably because of cultural problems and probably because of the way the medical system works, access by patients of color was likely limited. So we looked at aspects of diagnosis. First, we looked at the symptoms and we said, okay, here's a list of symptoms, and you can see those along the right side of your screen. Was this symptom significant for you at any time? And you can see that fatigue, tachycardia, dizziness, lightheadedness, brain fog, headache, those were greater than 80%. And you can see that decreases as we go down. Females had more nausea and had more palpitations as compared to males, but there were no other differences by sex. When we looked at the number of symptoms, all patients had 85% of patients had at least 10 symptoms. However, females were much more likely to have more symptoms than males at the 10 symptom threshold and 15 symptom threshold level. So you can see 85% of patients had at least 10 symptoms, 57% of patients had at least 15 symptoms, and 15% of patients had at least 20 symptoms. We then looked at severity of these symptoms. So we said, okay, here's the list of symptoms. Here's the ones you've had. On a scale of 0 to 10, rank the symptoms at its worst, at its best, and then last month. So the median severity range at its worst was 7 to 10, not surprisingly. At its best, that severity range was 0 to 3. Last month, the median symptom severity range was 2 to 5. Okay, so the worst persistent symptoms were fatigue, brain fog or cognitive dysfunction, headache, muscle pain, joint pain, exercise intolerance, insomnia, heat intolerance, and sweating. Interestingly enough, not dizziness, palpitations, tachycardia, or nausea, okay, which you would sort of expect with orthostatic intolerance. What we found was the number of patients who had a total symptom severity in the prior month of 0 for all symptoms was 2. That means, actually, that should be 99.1%. 99.1% of patients had at least one symptom in the prior month, okay? The median total symptoms in the prior month was 13. So a lot of symptoms, still 9.5 years down, with a range of 10 to 16 symptoms in the prior month. Females had more symptoms than males did in the prior month. And the symptom severity was higher in females as compared to males as well. Females had a 56, whereas males had a 42. When we looked at the onset of the symptoms of POTS, the median age of onset was 13 years, and we've shown that in a prior study as well, our demographic study. 56 patients had a trigger, something that you could identify within 3 months of the onset of their POTS. Nearly half of them, of those patients who had a trigger, had an infection that was thought to be the trigger. Over a third of them had some sort of an injury, including concussion, trauma, or surgery. 13% of patients had pubertal changes or a growth spurt, and nearly 10% had an immunization. Or stated that the immunization was what they felt was to be their trigger. The human papillomavirus vaccine was the most common, you can see there. Nearly 22% of patients had sudden onset of symptoms, but without an event. And 30% had no known trigger. Of those, 69% had a gradual onset. And in those patients, males tended to have more of a gradual or insidious onset. So now, before the diagnosis of POTS, we asked questions, and these are from the Big POTS study. We asked questions about how patients were treated and evaluated. So we found that 73% of patients had a doctor who did acknowledge a physical illness but was not sure how to proceed. But nearly 2/3 of patients were told they were suffering from a psychological or psychiatric disorder. And over half were told that their symptoms were all in their head or something similar. In their own opinion, however, only about a third felt they had a psychological or psychiatric problem. And there were no differences between females and males. After the patients were diagnosed with POTS, still about half of patients were told that they were suffering from a psychological or psychiatric problem. Around a third were still told that their symptoms were in their head. And 46% of patients were being treated at the time for a psychological or a psychiatric disorder. The comorbid diagnoses that were reported by patients most commonly included migraine. We saw Ehlers-Danlos syndrome, irritable bowel, gastroparesis. Mast cell activation syndrome is 21.5%. And the reason I mention this is because there's another study that was published by Dr. Larry Afrin that suggested that about 10% of POTS patients had mast cell activation syndrome. Reflex neurovascular dystrophy, complex regional pain syndrome, or amplified musculoskeletal pain syndrome is about 8%, fibromyalgia at 7%, small fiber neuropathy at 6%, and then you can see these other disorders as well. Except for Chiari malformation, the rest of these are autoimmune disorders. So some important points to come out from the diagnostic section of our long-term outcomes survey. The mean symptom duration is 9.5 years, one of the longest studies in the literature. There was a female predominance, which we already knew, and a white predominance, but again, the racial findings may not reflect reality due to the racial healthcare access disparities that undercount persons of color. We did find, however, that female patients have a higher predominance of symptoms and a higher severity of symptoms than males. Symptoms are still present in the vast majority of patients. The median age of onset was 13 years, which we already knew as well. Over half of patients had a trigger, and of those patients who had a trigger, nearly half of those had an infection, and over 1/3 had some sort of trauma, surgery, concussion, that kind of deal. 2/3 of patients had their symptoms attributed to a psychiatric cause, and nearly half were still being treated for a psychiatric diagnosis after their diagnosis of POTS. As far as the comorbid diagnoses, up to 30% of patients had an autoimmune disorder, although it depends on what you count. There may be more. That includes the 21.5% with MCAS. Turning to the therapeutic and clinical outcomes, we first looked at quality of life, or QOL. So for our patients who were under age 18 at the time of the survey, we used an instrument called the PEDS QL. And it's a 0 to 100 scale, and a higher number is better. And you can see here that in physical, emotional, social, and school functioning, as well as total score, the numbers hung out between about 50 or 60, which means moderate impairment from a quality of life standpoint. There's no differences between females and males. For our older patients, we used something called the SF-36, same scale, and again, higher is better. And except for pain, which you can see that males had a higher score than females. In other words, females experienced more pain than males. Again, the scores tend to hang out around the 40 to 60, 30, 38 to 40, 38 to 60 or so range, meaning that there is moderate impairment in quality of life. So, and here's our summary. For the PEDS QL, there was a moderate decrease in quality of life. And for the SF-36, a moderate decrease in most domains, although the most severe decrease was in role limitations due to physical health, energy and fatigue, and general health. And a mild decrease in quality of life in pain for males versus moderate in females. We also looked at medications. We reviewed 51 medications. We said, did you ever use this? Are you currently using it? And how effective was it? And we split it up into 0 to 25%, 26 to 50%, 51 to 75, and 76 to 100%. And we used a threshold of at least 50% as effective. And we also split this out by sex. We did the same with 24 alternative therapies. So let's look at these. For medications, the highest utilization for medications included melatonin, salt supplements, and actually those are, you could argue that those are, quote, alternative therapies because they're supplements, they're not actually medications. Fludrocortisone, methylphenidate, and ondansetron. And truthfully, this partially reflects my practice. This is the way I was managing these patients at the time. There were no differences by sex noted. However, when we looked at current utilization, the most frequently used medications were ondansetron, salt supplements, clonidine, metoprolol, and melatonin. So that reflects persistent symptoms. Interestingly enough, dizziness and nausea were not listed as chronic symptoms if you go back to the first portion of our talk this evening. So kind of interesting that patients were still listing that. And there were no differences in sex. From an efficacy standpoint, ondansetron, fludrocortisone, modafinil, salt supplements, desmopressin, and mixed amphetamine salts had the highest reported efficacy, and there were no differences in sex with those. The rest of the medication efficacy ranged between 22 and 41%. The numbers were too small to do any statistical analysis on. When we looked at complementary and alternative therapies, the highest utilization was the Levine, the Dallas modification of the Levine exercise protocol. In other words, the version that I ended up using at the Children's Hospital of Philadelphia is the one that you can find on Dysautonomia International's website. For those folks who are not familiar with it, but have heard of the Levine protocol, the CHOP Dallas protocol was modified for adolescents. So just be aware that it was not necessarily intended for adults, although a lot of adults have been using it. Further on down with utilization, dietary changes, aerobic exercise, and stretching. Interestingly, females were more likely to use yoga than males. When we looked at what was being used currently, stretching, aerobic exercise, resistance training, dietary changes, and cognitive behavioral therapy. Females were more likely to use over-the-counter topical agents than males. And this is really interesting. So we go back a slide, and 65% of patients started out using the Dallas protocol. However, by the end, only 13% were still using it. Which I think is interesting. A lot of patients stopped using it and moved on to something else, stretching, aerobic exercise, resistance training, etc. As far as efficacy in reducing symptoms, aerobic exercise was felt to be very helpful. The Dallas exercise protocol was also felt to be helpful, and resistance training. And then dietary change came in fourth with that. The rest were much smaller, with numbers too small to assess. When we looked specifically at dietary changes, we asked, did you use this diet and are you currently using this diet? And we looked at dairy-free, gluten-free, a low FODMAP, low carbohydrate, high protein diet, and a paleo diet. And what we found was the dairy-free and gluten-free diets were not only most frequently used, but most frequently still being used at about 15% each for those patients who were doing dietary changes. There were no differences between the sexes here. When we looked overall at the various interventions, and we said, what was most beneficial to you? The majority of patients felt that the addition of medications was most helpful, followed by increased fluid and salt, and then increased exercise. Interestingly enough, we asked, do you still need increased salt, water, and exercise to manage your symptoms? And 90% of patients said yes. Again, there was a difference between females and males, with 93% of females versus 72% of males still needing the non-pharmacologic interventions. So what did we find? We found that patients had moderate quality of life impairment with some severe with energy and fatigue and general health decrease. Males reported less pain. The currently used medications included ondansetron, salt supplements, clonidine, metoprolol, and melatonin. The most effective medications were ondansetron, fludrocortisone, modafinil, salt supplements, desmopressin, and mixed amphetamine salts. And the currently used and most effective alternative non-pharmacologic treatments included exercise and dietary changes. The most effective dietary changes were those that were either gluten-free or dairy-free. And the overall most effective therapies were medications, fluid and salt increase, and exercise. Males appear to have better outcomes with lower prior month symptom severity, fewer prior month symptoms, and less likely to need continued intervention. So obviously the question comes up, is there a difference from a hormonal standpoint? Likely. So from this first half of our study, the rosy picture that has been given in the past, despite the efforts of multiple authors, isn't so rosy. Symptoms are persistent in most, but they are treatable and can be variably controlled, but not everybody improves. And the many comorbidities need to be recognized and treated as appropriate. Our later research, which will be submitted in the coming year, include our educational, employment, and social impacts and gynecologic associations. So the bottom line, yep, POTS sucks for lots of reasons. So just wanted to acknowledge the folks at the Children's Hospital of Philadelphia Mitochondrial Medicine Frontier Program who took over both my POTS database as well as the research funding that allowed the private research funding that was given to me by a number of families, and I appreciate them very much. So these folks helped me put together the long-term outcomes survey. All right, guys, that's it. So I'm going to stop sharing.
All right. I have been quiet because when we started the webinar, this is Lauren Stiles. I have been quiet with my camera off because when we started the webinar, I was having a bit of an asthma attack and a mast cell reaction. Yay. So, but Dr. Boris is a pro and he just jumped in and started the webinar without my didn't need my help. So we have a bunch of questions. You can use the Q&A feature to type in questions on the bottom of your Zoom panel. There's a little Q&A tool. And I put a link in the chat to the first paper that Dr. Boris had published that he referenced, the long-term POTS outcome survey, diagnosis, therapy, and clinical outcomes. So you can check that out. So are these findings exclusive to pediatric POTS? What was the age range?
Right. So the age range was actually 11 to 30. So these, like I said, the average age of these patients was 22. So there were definitely adult age patients who took this survey. Now, having said that, it's younger adults, right? 30-ish. So you know, is this something that we see in 40 or 50-year-olds? And the answer is from my data, we can't tell, but Dr. Satish Raj and his team at the University of Calgary have actually put together a study that looked at POTS patients specifically after having at least 20 years of symptoms. And what it sounds like is they're still seeing chronic involvement as well.
Yeah. So, here's a question. Were any of these results from the patients that you did the genetic study on at CHOP? And what the person asking says, we were part of that. So
Yeah.
thanks for being part of that research.
Thank you so much for being part of that. I actually just presented our Genomic Association data at the American Autonomic Society annual conference last week. So, are any of these results from the patients? So, I do not know the names of the patients who were involved in the genomic study, and I actually don't know the names of the patients involved in the long-term outcomes survey. However, since you put your name on there, so Alexia, if you participated in the long-term outcomes survey and you participated in the DNA in the genomic study, then the answer is yeah, you were part of that. But I don't know the bigger. Those are two separate studies.
Okay. Here's a good question. Is the CHOP exercise protocol, it's on the Dysautonomia International website if anyone wants to check it out. It's at dysautonomiainternational.org/exercise, and you can download it. So here's the question. Is this CHOP exercise protocol effective for adults, even though it was developed for adolescents? And I know what the answer is to that, but I'll let you answer that.
Sure. So the answer is yes, but. So the answer is yes. It's a combination of aerobic activity as well as leg and core strengthening. What we did, though, to make it germane to adolescence is at the very end on the last page, I put heart rate ranges that are appropriate for adolescents and young adults, like early 20s. So what I would say is for adults who want to use the Dallas protocol, excuse me, I want to use the Dallas protocol. Be my guest, please do use it. The one thing that I would do is instead of using the heart rate ranges, you can use what's called the ratings of perceived exertion, the RPE. And so use that instead. And by the way, any of you who may be taking a beta blocker or ivabradine also do not use the heart rate. The heart rate ranges use the ratings of perceived exertion.
So I'm going to add on to that just for clarity. Even though the CHOP protocol that you've written and put on our site was sort of intended for kids because that's the kind of patients you were mostly working with. The original protocol, the research on that protocol actually was done on adults, and it showed efficacy in a subset of adults, right? So I know that Dr. Boris and all the other doctors on our medical advisory board don't think that this is the magical cure, quick fix for POTS, right? It's really hard to do the exercise. A lot of us, when we start it, we accidentally kind of do too much or push ourselves too hard, and then you crash really bad, and then you start to wonder, am I going to be able to do this at all? Should I do this? So my advice after having POTS for 14 years and having gone through everything from fully bedridden for 2 years to being able to go snowboarding again. But it wasn't a linear improvement, right? It's like a roller coaster. I think some patients have described it, where you think you're getting better and then you crash and you kind of have to start all over again. So be patient with your body and take it slow and easy. And I really think the most effective thing is doing what works for you, and whatever you can consistently do is better than pushing yourself really hard and then crashing for a week, the sort of slow, sustainable. There's actually a brand new study that just came out. It's posted to our social media today, from another research group in your actually Dr. Fedorowski and colleagues in Sweden,
Mm.
using a sort of like a different protocol than the CHOP one. It's not like publicly shared yet, but I think they probably will. And it's basically working with a physical therapist and dosing the exercise to the patient's individual need, which is great,
I
Um,
think what I would say about the Dallas Protocol too is that, and I think, getting back to the fact that a lot of patients started out with it, but very few patients stuck with it at the end,
yeah.
is it's boring as hell. It
It's hard, and
really
it's hard. It's like
it
for
really is.
me, it
And
was too much too fast for me, but
And and so, for those patients for whom it's too much, too fast, I mean, it starts out day one is 10 to 12 minutes, and I'm like, start off with 3 minutes. It's okay to start off lower. But the reason I like the Dallas Protocol in general is because early on, it's very prescriptive. It tells you exactly what to do. It has you start out recumbent, in other words, not upright exercise, and it increases you slowly. But by the time you get to month 4, 5, 6, it's okay to transition to something else that you enjoy because in the end, you do need to be exercising regularly because that helps to suppress the POTS symptoms. Um, and so you want to enjoy it, and especially for adolescents, and especially specifically for adolescents who haven't exercised on a routine basis. It's really hard to get them going. And so finding something that works for you once you get down the road a little bit, is going to make it much more enjoyable.
yeah. So here's a good question. Did you see any difference in the results that in the patients you've seen, in those who have Ehlers-Danlos syndrome and those who don't?
Um, we did we break that out? That's a great question. I need to go back and look. I think we might have broken that out and didn't see any difference, but I'm gonna have to go back on. I think, you know, one of the things that I would do differently in designing the study again is everybody gets really, really, concerned and about, Ehlers-Danlos syndrome specifically. But there's more patients who actually meet criteria of what's called hypermobility spectrum disorder, which means they don't meet full criteria for hypermobile Ehlers-Danlos syndrome. And in the end, in my opinion, I think it doesn't matter whether you have EDS versus HSD. It's more that you have a connective tissue disorder, and it's more about managing the joints, managing the connective tissue issues that come along with it, and going from there.
Yeah. And so when you're starting to try to exercise or even, I kind of almost hate the word exercise because that means different things to different people. And
Mhm.
some people envision exercise as like a hardcore workout in the gym with weights and treadmills and all that. And then for other people, exercise is like, I got up to do the dishes, like and sometimes you could be both of those patients, right? You could be someone who on one day can walk a mile and on another day you can barely make dinner.
Well,
Uh,
classic story.
yeah,
POTS patient has a good day, exercises like normal, and then they're dead for the next 3 days,
yeah,
right? Which is what we don't want, right? So that's why the Dallas protocol, the Levine protocol, starts out with recumbent exercise.
yeah,
So you're not destroying yourself so badly today that you can't exercise tomorrow.
yeah. What I was just going to say, for everybody, but particularly for the patients who have EDS or significant joint hypermobility or joint instability issues, it's really important that when you do exercise, you're protecting your joints and you're not straining them. And sometimes it's not really intuitive how to do that. So if you can find a physical therapist who
Yep.
is EDS, dysautonomia savvy, they can usually guide you in the type of bodily movements and, resistance training that you can do that doesn't put an unnecessary strain on your joints and risking injury. Because the worst thing is like, you already have chronic illness, and then on top of it, you sprain your ankle and you can't walk for 3 weeks. So you want to make sure you're protecting those joints. A related sort of exercise topic is, chronic fatigue syndrome and post-exertional malaise that patients have. So this is sort of, it's always sort of a lightning rod when we talk about this in our
Mhm,
patient
mhm.
community. And I think um, there are a lot of perspectives on what people can and cannot do based on, diagnostic labels. But I think we just need better research to tell us, um, how is that different? How is that the same? And what I would love to see in these studies on POTS and in the studies on chronic fatigue syndrome, like as an organization, we've tried to get the POTS researchers to screen for post-exertional malaise using the standard tools for that, and to kind of screening for chronic fatigue syndrome, and then trying to get the chronic fatigue syndrome researchers to screen for POTS and other autonomic dysfunction. But it's sort of like there's these two different universes of research and they don't often overlap. Okay, so anyways, the question in that is from a patient is, so if you have post-exertional malaise, how does this affect your exercise attempts in POTS?
And we didn't really look at PEM, specifically. I do think, I do think that PEM can restrict your ability to recover. I think it can restrict your ability to psychologically just accept wanting to do exercise because it makes you feel crappy. And so, um, um, I will be honest, I don't know enough about managing patients with ME/CFS though. Um, uh, on specifically on how to deal with PEM. I do want to get back to the joint hypermobility and the physical therapy thing real quick. What I tell my patients is when they go to the physical therapist, I want them to learn at least four things. The first is how to strengthen the muscles around their joints. Your connective tissues should be acting as guardrails for your joints so they don't go past the normal range of motion, but they're so stretchy that your joints go past the normal range of motion. So learning to strengthen the muscles around the joints to act as those guardrails is really very important. Number two, learning to be aware of where your joints are in space so you don't routinely take your joints past the normal range of motion. Number three is learning judicious use. So not all the time, but just if you have chronic routine, if you have chronic repetitive use of your joints, but judicious use of bracing and taping. Um, so that you don't injure yourself if you have repetitive motion activity. And the fourth thing for my female patients is pelvic floor strengthening.
Yeah. Here's a good question. And actually, we've got some research grant applications on this topic. Oh, I should just mention to everybody in the last Friday, our 2024 grant applications were due. The first stage, it's called Letters of Intent, where a researcher will send in a 2-page letter saying, this is the kind of research I want to do. And we had 1.1 million in funding available, thanks to our amazing donors and everybody who gets out there and volunteers and helps with fundraising. And we got $9 million in research grant applications, including some studies on this question. What can you say about low iron and ferritin in POTS?
Right. So there's actually been at least one, if not two papers published. One I know came from Mayo Clinic, and that is a low ferritin is associated with orthostatic intolerance. So in my patients, a ferritin level is one of the laboratory studies that I routinely get when I evaluate them. And I know the Mayo Clinic likes to shoot, at least historically, has liked to shoot for a ferritin level greater than 25. However, Neurologists who treat patients with restless leg syndrome like to shoot for a ferritin greater than 50. And so when I read that, I'm like, that's what I'm going for. So in my patients, I shoot for a ferritin greater than 50. And actually, in some RLS patients, they go for over 75. I know some adult cardiologists who manage patients with heart failure, they go for a ferritin greater than 100.
Yeah.
So, um,
So
certainly making sure that and for those that are not aware, um, when we assess iron, we get what's called an iron panel, but we also get a ferritin level. And the ferritin is your total body iron content. So that's the one that I actually look at, not just the iron in the bloodstream, but the total ferritin.
yeah, on the grant applications that came in from some very, very highly respected POTS research centers, which Dr. Boris knows.
Mm.
Um, the cutoff levels for the studies that they've proposed to us are patients with a ferritin of 50 or below would get iron infused in the studies.
Oh, wow.
So they're looking at 50, and there was one looking at 55 and below. So, yeah, that I think, one of the research questions is actually what is the optimal ferritin level for for a POTS or dysautonomia patient?
Yeah,
That will come with future research.
sure.
Um, so, if you have low ferritin levels, uh, what type of treatments are you using in those patients when you see that?
Yep. For those folks who have never taken an iron supplement before, um, most iron supplements tend to cause a little bit of abdominal pain or constipation. And that can be kind of off-putting, especially if you already have gastrointestinal dysmotility, nausea, constipation, that kind of deal. However, I am forever learning from my patients. My patients are always teaching me. And a number of years ago, some patients taught me about an iron supplement called Vitron C, Vitron C. It is a combination of iron and vitamin C. The reason for that is because when we take iron in any form, be it part of meat or spinach or wherever green, leafy greens, that kind of thing, or in a supplement, we don't absorb very much of it. So a lot of it just gets passed through us. However, vitamin C enhances that absorption of the iron. And so the nice thing about Vitron C is it's a combination of both iron and vitamin C. And from a GI standpoint, it is reportedly much better tolerated than most iron supplements. Um, Conversely, by the way, for those folks that drink a lot of tea can inhibit iron absorption. So my recommendation would be if you do drink tea, don't take your iron supplement around the time that you're having your tea.
Yeah. Um, I actually have a family member who was drinking a lot of probiotics, the like liquid kefir drinks, that it's
Mhm.
the milk-based product. And
Yeah.
they drank so much milk that they got an iron deficiency because they had like too much calcium. Like there's something when you have like really excessive calcium and milk intake that you can mess up your red blood cells a little bit.
Mm.
Um, so think about that too. Okay, so here's another. We have a lot of topics, and I know like each one of the questions people are asking is an amazing question that could be its own webinar and its own study. So try to bounce around a little bit to get as much broadness to this as we can. So so there's some questions about vagus nerve stimulation. This is an area of deep interest for me, but do you have any thoughts on this are you using this in any of your patients?
Am I using it? I'm not routinely recommending it. That doesn't mean that I'm discouraging it. It's just that I want to see more data. Um, you know, uh, Dr. Kevin Tracy, and I think actually wasn't
He was our keynote, yeah, like
yeah, that's what I was
during
going to say.
COVID.
Kevin, Dysautonomia International had Dr. Kevin Tracy speak a couple 3 years ago about vagus nerve stimulators. So the original vagus nerve stimulators were surgically implanted, okay? And what they did was by sending out a signal that would stimulate the vagus nerve, what they found was it caused the spleen to reduce its output of tumor necrosis factor alpha and interleukin 6. Both of those are inflammatory mediators. Okay. So the thought was, all right, well, if we, the vagus nerve extends to a lot of different parts of the body, and one of the places that it extends to is to the outer ear. So, would we be able to successfully stimulate the vagus nerve by sending an electrical signal through this branch of the vagus nerve that comes in the ear? So that's where the external vagus nerve stimulators come from. And I think there's a lot of there is increasingly promising research that show that VNS devices can be helpful. Um, I want more data. um, I want more data before routinely recommending these, especially since some of them are like subscription model, and I'm just, yeah, I think before we have patients spend a boatload of money, we need to make sure that they are not getting hurt and make sure that they are getting benefit.
So here's where I throw in my I'm not a doctor 2 cents. We have funded Dysautonomia International, thanks to our donors, have funded uh 3 different vagus nerve stimulation trials on different devices because we were more interested in the concept, the mechanistic concept of vagus nerve stimulation rather than like trying to just pick one device that our community should use. We think once you prove that it's helping, then you do like comparative efficacy studies to see like which device is helping the best, right? And is the most tolerable and safe and everything. So the 3 different devices that we had funded research on, one is called IB Stim, and it's actually FDA approved for pediatric IBS in the US. And some insurance companies are starting to cover it. It's kind of a bit of an awkward device. It's these sort of little electrodes that go in a couple different spots on the ear, and they put this big glob of sticky tape on your ear, and they keep it there for 7 days. And we have had quite a few patients say, I did this, and my POTS went into almost remission or dramatically better for like a month, for a few weeks. Like it isn't a permanent fix. You have to keep doing the stim. So that paper, the study was done by a doctor at a pediatric GI doctor at Children's Wisconsin, Dr. Katya Kovacic. And so that paper is in like waiting to be published. Like it's been submitted and it's in progress and just takes a while to get through peer review. But that should come out this year or early next year. We also funded a study in Europe at Humanitas University, and they were collaborating with the folks at Vanderbilt on a device called NEMOS, which is a European approved, like the European version of FDA, European Medicines Agency. It's approved for seizure disorders in Europe. So they studied the NEMOS device, which is a vagus nerve stimulator, and they published their results, and it had a very good improvement in quality of life and efficacy. And that's the kind that you can stim a little bit every day, a few minutes a day on your ear. And that's not available for sale in the US, and it's very hard to get your hands on it in Europe if you don't have a prescription for seizure. So it's like, in progress, trying to get more access to that. And then the third device is a device called Parasim, uh, that is based out of Europe, but they are actually going to be working on US research. They have funded some research themselves at centers in the US that we have also funded. And that work was mostly being done at University of Oklahoma. Dr. Stavros Stavrakis, he's got a bunch of POTS patients. And they have published some papers. I shared one of the links to one of his papers in the chat if anyone wants to take a peek at it. And that device is, they won't ship it to the US. You can buy it it's got European approval, surprisingly, for dysautonomia, like a broad umbrella term, right? But when then they came to the FDA and they said, we want to get an approval for dysautonomia in the US, the FDA said, well, in the US, we specify the type of dysautonomia since they're all very different, right? Some types of dysautonomia, you wouldn't want to stimulate the vagus nerve. It's like sort of the opposite type of dysautonomia. So anyways, that device They won't ship it to the US, but if you happen to have a friend in Europe, you can get them to order it for you and ship to the US. Not that I'm telling you to ship things illegally, but it is possible. There's also a bunch of devices in the US that are of varying quality and efficacy that you can find if you sort of Google vagus nerve stimulators. I'd be really cautious about any device that isn't actually stimulating the concha of your ear, which is the little kind of curved part on the inside of your ear. It's not the place where people get the daith piercings on their ears, the little kind of tab on the side of your face. That's not where you need to be stimming. If you look up auricular branch of the vagus nerve, you can kind of see maps of where the vagus nerve is in the ear. But anyways, this is, most doctors, even POTS experts, are not routinely prescribing this yet because they want to see more data. So, but patients are out there trying to get access to it. Like many things in research.
So there's a question, can you speak to any research using medication called Mestinon? And the answer is yes, I can. We actually published a study several years ago on just various medication efficacies for various symptoms in POTS. And Mestinon is a medication that I use a lot. I specifically use it for patients who have gastrointestinal dysmotility. So if they have nausea, early satiety, meaning feeling full early, constipation, that kind of thing, I feel that that it does make a good difference for a lot of patients. There's some really interesting research that shows, and I don't know if it's been published yet. I think that was David Systrom up in Boston was doing cardiopulmonary exercise testing, and what he found was that Mestinon also improved the return of blood to the heart from the body. So what that means is a lot of times POTS patients pool their blood, right? They pool their blood in their extremities and they pool their blood in what's called the splanchnic circulation, the blood vessels in their abdomen. And so Mestinon was able to improve that in some patients by cardiopulmonary exercise testing. I don't know if that's been published yet, but I've heard him present that data. In my experience, I've had most patients who respond to Mestinon specifically improve from a GI standpoint. I've had a small percentage of patients improve from a cardiovascular orthostatic intolerance standpoint. There's another question.
Wait, I want to jump in. Sorry. There's a paper. So we were just talking about vagus nerve stim, right? So Mestinon, pyridostigmine, is essentially like the pill version of vagus nerve stim. It's not exactly the same, right? But it's got some similar pharmacological properties. And there's actually some papers showing that Mestinon reduces inflammation through the same receptors that vagus nerve stimulation works on. So I just wanted to tie that into our last question.
That's interesting. Wait a minute, there's another question that I saw in here about fatigue. Yes, here we go. It looks like fatigue was the largest percentage of symptoms, which is my daughter's too. Any studies yet on specifically how to correct that? And I published on that too. That same set of analyses where we used medications for a number of other POTS symptoms. We published a separate paper on treatment for fatigue and brain fog, cognitive dysfunction. And we had very good success, like 69% efficacy using stimulants, Ritalin, Adderall, Vyvanse, Focalin. A small percentage of patients had improvement with atomoxetine or Strattera, and then using Provigil or Nuvigil. Interestingly enough, with fatigue and brain fog, the research, and this is actually studies that have been done at the Dysautonomia International conference, as well as and sponsored by Dysautonomia International as well. Fatigue and brain fog are associated with decreased cerebral blood flow, decreased cerebral perfusion. And so improving that blood flow to the brain can reduce fatigue and brain fog as well. I've had a small percentage of patients who take midodrine have reduction in their fatigue and brain fog also. And I've also had some patients who have comorbid mast cell activation syndrome when we treat their MCAS, their fatigue and brain fog improve as well. So it sort of depends, but the best outcomes, you saw the most effective medications like included methylphenidate and mixed amphetamine salts and modafinil. Those are the generic names for the medication, the stimulant type medications that we were using for fatigue and brain fog.
Yeah. So here's a question from someone that is a common problem in our patient community. The person says, my doctor refuses to prescribe me any meds. What can you tell me about licorice? So the licorice is sometimes used as sort of a natural version of fludrocortisone.
Yeah.
But there's some concerns about that. Can you speak to that a little bit?
Yeah, so licorice root, and I've actually used it as in some of my patients, like I did when I was at Children's Hospital of Philadelphia. I had patients who didn't tolerate fludrocortisone, and I used licorice root, but it works kind of the same. The way both fludrocortisone and licorice root work is they work at the level of the kidneys to hold on to salt and water. So similar to aldosterone. Aldosterone is your natural hormone that works at the level of the kidneys to do that. And so one of the and Lauren, I'm kind of curious as to what your concern you're thinking about is, but the big issue with licorice root kind of goes to the bigger topic of supplements. And that, in my mind, and that is that supplements are not overseen by the FDA. And so you have no guarantee of the content, you have no guarantee of purity, you have no guarantee of lack of interaction, good or bad, with other medications. And in reality, there's no research on it. They don't have to have any research because it's just a supplement and quote, not intended for medical use, right? So Lauren, I'm interested in what your issues that you know about it.
It's not really like a don't use it kind of issue, more like so fludrocortisone comes in very measured doses where you know the amount of drug you're being given based on what's been prescribed. And licorice, can vary, like it comes from a plant, right? So it can actually vary in the strength and the potency of the active compounds that are in it. And so there are some published journal articles on people who've sort of given themselves like a pretty significant um, sodium balance problem because they
Yep.
took too much licorice.
Yep.
So I would just caution anyone who's thinking about using it. Like, first, I would say, I'm really sorry if your doctor is not willing to help you. And I know it's easy to say this, but like, try to find a better doctor if you can. I know not everyone can do that because some people are just on, insurance plans that only cover certain doctors, or you're in a really rural area and you're kind of stuck with the local person. But if a doctor is like refusing to give you any medications for POTS and you're not well and you need to feel better, there's no like scientific reason to deny someone any access to medication. So try to find a better doctor. But if you're not able to do that and you want to try things like licorice, like just go really slow and don't assume more is better because sometimes more can land you in the hospital. So just be careful with it.
Mhm.
And licorice just shows up in a lot of places. I was getting this ginger root turmeric tea that I bought for like anti-inflammatory properties, which I think is a big underexplored area in our treatment approaches to POTS, is like doing dietary things that are sort of overall anti-inflammatory. But I didn't realize it had licorice root in it, and it actually kind of gave me some hypertension. And so it's like, and like I know about this stuff, and I just kind of missed it that it was an ingredient. So just be careful. But sometimes when you're really hypotensive, you might want a little hypertension. You might want to help that out. I think we should take one more question because it's at the hour, and I want to let Dr. Boris go to bed at some point tonight. So Let's see. Oh, here's okay, a good last minute question. If you're taking fludrocortisone, are there any concerns about potassium levels or some kind of result of osteoporosis or bone problems with long-term use?
Right. So historically, um, fludrocortisone, there in the medical literature, there has been concern that it has the effect of what's called a glucocorticoid. A glucocorticoid is like prednisone or prednisolone or dexamethasone. Those are steroids, and Florinef is a steroid too, but it's a mineralocorticoid. Glucocorticoid effects are the ones that cause decreased bone density, they cause increased fat collections, they mess with your sugar metabolism. They do all kinds of stuff if you take them for a long time and you are taking them in fairly high doses. However, fludrocortisone really doesn't have that effect, despite what some folks say. I've had patients on Florinef for years and they do just fine. The doses that I use are 0.1 and 0.2 milligrams. At the higher dose, there is a slightly increased risk for decreased potassium and or decreased magnesium. And so I will go ahead and get laboratory studies to evaluate for that on a routine basis. But beyond that, pretty well tolerated. So really shouldn't be a concern as a primary cause for, say, osteoporosis from that standpoint.
Yeah. All right. Well, thank you so much for your time, as always, and the good work you do for our patients and the cool research you're doing. We are looking forward to sharing the other articles when they come out. And just for anyone who it didn't, if you tuned in late or if you know someone who registered for this and they couldn't attend, we have recorded the webinar. So in like about 2 weeks, we'll email everyone who had registered for the webinar, whether you attended tonight or not. We email all the webinars out to the registered webinar attendees, and it takes about 2 weeks because we have like some volunteers who edit the video and make it look cute and put it on our website for us. So thanks so much for everyone tuning in, and don't miss out on our future webinars. We have a webinar every month. And also, wait, last minute, just want to give a shout out to our annual conference. We have a save the date. We don't have the registration page open yet, but it's going to be July 11th through 13th in Raleigh, North Carolina. So we're hitting a different part of the country that we haven't hit before and hoping to see a lot of you there. It's always a fun event. Dr. Boris, hope you're not busy on the 11th weekend because you're invited.
Well, thank you. It'd be kind of nice to get back to North Carolina. For those that know me well, I actually used to live in Asheville, which of course got trashed by Hurricane Helene. But so it'll be nice to get back to North Carolina. Yeah.
Yeah. And it's in person and virtual. So if you for some reason you can't come, we have virtual options to be involved. So great. Well, thank you so much for your time this evening, and we'll see you online.
Great. Take
Take
care, y'all.
care. Bye.
Bye.